So here's just an outline of what I'm going to talk about today. Just a general discussion, some unanticipated consequences of criminalization, a discussion around what significant risk is, and whether viral load figures into that, and a quick discussion on some alternatives to criminalizing people with HIV. So just by way of introduction, there are a number of different charges that have been laid in these cases, but generally they include assault because non-disclosure of HIV where you don't talk about it or lie about your status is considered fraud and invalidates consent to having sex. And again, as Michael mentioned, the charge is often aggravated sexual assault because it endangers the life of the complainant, in their opinion, and this charge can lead to life imprisonment. So, I think we have to take a step back and think about if we're convicting people with HIV of really serious crimes, with sentences that can be up to life in prison, while also publicizing their private health information. We shouldn't make these decisions lightly. And if our justice system is going to be applying punitive measures like this, where's the evidence that it works? Is it a deterrent to having unsafe sex? And really, does it decrease transmission? So is the law a deterrent? No, there's no evidence out there that having laws on the books or in the courts causes people to disclose more or practice safe sex more often. Sort of additionally, there are concerns from public health practitioners and healthcare practitioners that criminalization actually deters people not from disclosing to their partners, but deters them from disclosing to public health officials for fear that those same people that are supposed to be helping them in their health will then be brought to court to testify against them. Additionally, this law sort of targets the wrong group of people. We know that in the literature that people who know that they're positive reduce their the amount of risky sex that they have and take steps to keep their partners safe. And also, it's probable that transmission rates are actually higher in people who don't know their status, and usually those people are people who are acutely infected, whose viral loads are upwards of 1 million copies per mil, and they won't test antibody positive, but they're actually more infectious than someone who's aware of their status and takes steps to reduce the risk to any sexual partners that they might have. Another sort of unanticipated consequence of criminalizing people with HIV is they can go to prison. And I think many of you know that there's a serious problem in our prison system with harm reduction practices. There's very little access to clean needles, to condoms, and additionally, there's really poor access to highly active antiretroviral therapy in prison, and adherence to these medications can be really low in prison settings. There are a lot of cases of people having really long, extended interruptions to their treatment when they've been imprisoned because the healthcare systems there aren't connecting with their regular healthcare provider and can lead to really lengthy times off treatment, which then, if you're positive, your viral load will go back up, and it's likely that you'll be more infectious than if you were on treatment. We should also touch on, why is it that HIV is the target of these criminal prosecutions? There have been other cases with Hep B, Hep C, and herpes simplex, as Michael mentioned, but no convictions, luckily, in those cases. But there are other STIs and other infections that can be transmitted that lead to things like cervical cancer. The flu kills upwards of 4,000 Canadians a year, but no one's getting charged for sneezing on the SkyTrain. I think really the issues around why HIV is sort of singled out include HIV panic and stigma, really misinformation about transmission, and also what it's like to live with HIV nowadays. So I'll discuss a couple of those things. We say it all the time, and it can, get sort of tired. But HIV is not a death sentence anymore. And the Currier case, where the main Supreme Court decision came out of, was made in 1997. And just to put that into context, HAART was only around for a year at that time. There were very limited and really toxic treatment options for people at that time, a high degree of drug resistance. Whereas today, we have upwards of 25 ARVs that are available to people. You can take one pill once a day. There's declining resistance, and at the same time, increasing life expectancy for people living with HIV. And so really the context that the Currier decision was made in is a very different context than the one that we all work in and live in today. So in terms of significant risk, a charge can really only be laid in cases where there is a significant risk of transmission, whether or not transmission actually occurred. And this idea of what significant risk is one that there's a lot of discussion around. And so I just want to sort of frame it, the riskiest risk that we think about with HIV transmission is receptive anal sex with someone who's HIV positive, and even that risk is relatively low at about 0.5%. And receptive vaginal sex, if you're a woman, has actually probably a lower risk of transmission when your partner is known to be positive. And oral sex without a condom, because oral sex with a condom is gross, is almost negligible. But speaking of condoms, condom use in anal sex, in vaginal sex is very, very effective at preventing HIV transmission, and that's why all of these community groups really try to encourage people to use condoms. It's a good thing. But even still, there are still cases that come forward where people who use condoms consistently are being charged. And so really there are conflicting messages coming from our healthcare sphere and our public health sphere, around condom use, around serosorting, seropositioning, where we're hearing these harm reduction messages, but then our law system is not aligning with those same messages. So it would be nice if we had alignment in the law of sort of the evidence that we know exists in public health and in healthcare, and if those two synced up a little better. And some other consequences of criminalization is that really, when you know your status, it's then that you can be charged. And if you don't know your status, then, well, I didn't know that I was HIV positive, and so how could I know that I was putting my partner at risk? And so that really, we think, deters people from getting tested, or at least is a factor that people think about before they might get tested. So now I'll just talk about viral load. In terms of significant risk, there's some discussion if condom use is generally considered to be a reduction in significant risk in these cases. Does viral load count in these cases as well? And so when you're on treatment, your viral load goes down, and it goes down to levels that are undetectable by our the assays that we generally use. We also know that people with naturally lower viral loads are less likely to transmit to their partners. And so, I think generally there's an understanding that people with an undetectable viral load are not putting their partners at significant risk for HIV transmission. Yet we still have cases, in fact, one case where the judge actually used the defendant's defense that they had an undetectable viral load as a reason to give them a higher sentence because they were shirking their responsibility to disclose. So that's troubling. Just some data here for lower viral loads associated with reduced transmission. You can see the transmission rate per 100 person years is really low when you're around the range of below 400. And most of our treatment options nowadays, given how many treatment options there are and how much better they are than in 1997, people living with HIV and on treatment have very low viral loads generally. I won't talk about community viral load. Also, just the Swiss statement. Some of you may have heard about the Swiss statement. And there was a group of physicians and public health officials who came out and said that an HIV positive individual on ART and with suppressed viremia, while not having other STIs, is sexually non-infectious, and that was pretty controversial at the time that it was issued. But now this year we've gotten the results back from HPTN 052, which was a really, really large randomized clinical trial of almost 1,800 serodiscordant couples, serodiscordant meaning one was positive and one was negative, and looking at linked transmission events in couples where, so they split the couples into either the positive partner going on therapy right away, or waiting until they met the sort of current treatment guidelines in their respective countries. And in the group where the positive partner initiated therapy earlier, there was a 96% reduction in transmission reduction in infections to the negative partner. So just evidence that that treatment of HIV really reduces transmission. And finally, we have a clinical trial definitively showing that. So yeah, viral load. And I just wanted to touch upon it's also not clear in the law if you're positive and having sex with someone who's also positive, it's not clear whether whether that person can charge you with under this same law. And that's despite the fact that really the risk of superinfection is probably quite low if you're already infected. Superinfection being to get infected again with HIV. And in quite a few studies on this phenomenon, the sort of rates of superinfection have been very, very low. So finally, UNAIDS developed a sort of set of policies around these criminalization, and they recommended limiting prosecutions only to cases where there was intentional transmission, and in fact there was transmission, despite the fact that these cases are really rare. But really, rather than criminal prosecutions, we can do a lot better on decreasing transmission by using things like universal precautions. So I think in the gay community, we're more used to assuming that people might not know if they're positive, and assuming that there's risk when we have unprotected sex. And so, maybe thinking about universal precautions for sex. And also just really better education around HIV, how it's transmitted, counseling people on reducing their risk and reducing substance use. And really key is normalizing discussion about HIV so that people who are positive can feel that they can disclose in a safe environment without fear of rejection.